my name is Joy Prettyman, and this is my senior practicum. I am presenting on my chosen project, which was the community education option, and my topic was on hypertension. My project design was this. The goal was to spread awareness and education about hypertension, its risk factors, prevention methods, and management to the Central Savannah River area, or the CSRA, where I live. In doing this, I created a trifold display of information. I went into the community, interacted with members, and I educated and screened for hypertension. The display included information on the definitions, risk factors, prevention management, and prevalence of hypertension. My project was implemented, and I completed it at a local church in Aiken and on a college campus in Augusta. For my review of literature, I'm starting off with the first article that I critiqued in our journals. The title of this article was Partnering with Churches for Health Screenings in Urban Segregated Communities. The focus of the study was the role of faith-based organizations in addressing healthcare disparities. The objective was to highlight effectiveness of church-based health interventions in underserved urban communities. The study design was a community-based participatory research. It was evidence level 3 because it was descriptive and observational, and the population was urban segregated communities with barriers to healthcare access. The methodology they used was recruitment through church congregations and reaching diverse socioeconomic backgrounds. They screened for chronic conditions such as hypertension, diabetes, and cholesterol. The screenings were conducted by health professionals, and they used surveys, medical assessments, and qualitative interviews. Key findings of the study was that church partnerships significantly increased screening rates, and high rates of undiagnosed chronic conditions were detected. Additionally, community perception was that there was an enhanced trust and comfort through the church involvement due to it being a familiar environment, and the screenings raised health awareness. In conclusion, faith-based partnerships did address healthcare disparities effectively. The implications of this is that more screenings through faith-based partnerships could overcome cultural, logistical barriers and enable early disease detection and improve management of the diseases. Future directions this could go, the sustained partnerships with health-based interventions, doing that long term, assessing chronic disease outcomes over time could be another direction that this study could go in. The next review of literature I completed was for an article entitled Effectiveness of Community-Based Health Campaigns on Chlamydia Screening Uptake in Young People. The focus of this article was a systematic review of campaigns to improve chlamydia screenings in ages 15 to 24. And the objective was to assess whether community-based campaigns effectively increased screening and detection. The study design was a systematic review of articles. This was level 4 evidence. The methodology they used was to review a total of 19 studies. These were quantitative, qualitative, and mixed methods. Key themes identified from this were anonymity and relevance to the target audience increased screenings. And the tools that they used were meta-analysis to assess trends in screening campaigns. Key findings of the study show that increased test numbers but not positive results were correlated with community-based screenings. They also found that there was high variability in campaign success based on the differences of formats and audiences. They also found that prioritizing anonymity and relevance increased screening, and that there was a need for further research to optimize methods of screening campaigns. Strength of this article was that it was well organized, it had a good structure, and it had an academic tone. There were logical arguments supported by data. The method of meta-analysis provided quantitative credibility for observed trends. And the strength also was that they acknowledged their limitations by discussing their biases and lack of randomized trials. Limitations of this article were that there were high variability, there were differences among studies, and that weakened their broader conclusions. And the methodological issues were that they had a limited critique of methods in their reviewed studies. They also did have potential biases, and that was that the author's affiliations with public health institutions, and then they also had a heavy reliance on Western data and qualitative studies. Recommendations for this study would be to improve the cultural inclusivity of their research, to increase qualitative insights, to understand their target audiences, and to test innovative methods to engage high-risk groups effectively. A long-term goal could be to develop community-based strategies that not only increase screenings, but also enhance the diagnostic accuracy and the public health impact. Concluding insights, the campaigns modestly increased screening uptake, but there was no significant positive diagnoses detected. Review of literature is on an article entitled Cardiometabolic Risk in a University Community, an Observational Study. The focus of this study was prevalence of cardiometabolic risk factors among university staff, and their objective was to highlight health vulnerabilities in academic populations and propose workplace interventions. The study design was an observational study. It used level 4 evidence, and the population was conducted on university staff. The method used was a cross-sectional design. It was focused on a single institution, and it included self-administered online questionnaires and face-to-face assessments of university personnel. They recruited through an invitation using the institutional mail. Key findings of this article were that cardiometabolic risks had high prevalence of hypertension, sedentary lifestyle, and poor diet. Males and academics faced higher hypertension rates, and there was a low adherence to healthy dietary guidelines among participants. Sedentary behavior common, and it was also linked to increased cardiovascular risk. Strengths of the study were that it had a timely focus on academic populations because these populations face unique stressors and lifestyle limitations. Their strength was that it was clear, accessible writing for both medical and general audiences. The data presentation was very well organized, and it had clear risk categories and had accurate trends in cardiometabolic health. It was illustrated effectively. Limitations of this study were that it had subjective measures. It relied a lot on self-reported data for diet and physical activity. And then there is always the risk of overestimating your positive behaviors or underreporting your risks. Another limitation was that it focused only on one institution, so that limits its generalizability, and regional and institutional factors were not addressed. And there was also a lack of longitudinal data, as it was only conducted in a single snapshot of time. Recommendations for the study would be to advocate for workplace health programs to mitigate risks, focus on the preventative interventions. That would also align with public health initiatives promoting preventative care. Recommendation for improvement would be to include that longitudinal data, tracking risk over a progression of time, and to explore how academic work culture influences health risks, stress-related hypertension. It would also be a good opportunity to provide specific actionable interventions with cost-benefit analyses. Some concluding insights of this study are that the broader implications, workplace health interventions in universities could improve employee well-being and address systematic cardiometabolic risks. Also, there are future research needs of more diverse longitudinal studies and an analysis of regional, cultural, and institutional factors affecting health outcomes. My last review of literature is entitled Knowledge, Attitude, and Practice Regarding Hypertension Impact of Posbindu. This article focused on evaluating the Indonesian Posbindu program influenced on hypertension awareness and management. The objective was to assess differences in knowledge, attitudes, and practices between participants and non-participants. The study design was a cross-sectional descriptive data. It used level 6 evidence. The population was 1,988 respondents from 4 Indonesian districts. The participants were divided into Posbindu participants and non-participants. The method was a structured questionnaire assessing KAP, knowledge, attitudes, and practices of hypertension. Key findings. For knowledge, there were higher knowledge scores among Posbindu participants than non-participants. They recognized risk factors, including diet and obesity, and there were gaps in recognizing smoking and physical inactivity as risk. As far as attitude goes, non-participants showed slightly better attitudes. There was a greater emphasis on lifestyle changes alongside medications. As far as practices, there was marginal improvement in healthy eating and smoking reduction among Posbindu participants, but there was a limited consistency in exercise routines. Strengths of this study had a timely focus addressing hypertension in low and middle income countries. Program insights highlighted the role of community-based interventions in public health, and it was a very clear, well-organized structure with clear delineation of objectives, methods, and results. Limitations of the study included the cross-sectional design. It captured a snapshot, but it does not include causality. And then it cannot assess whether knowledge translates to improved behavior over time. Limitations also included biases, as there was a reliance on self-reported data, because many people may overstate that they do participate in positive behaviors. There was also an overrepresentation of older female participants in the Posbindu group, which may skew results. And then another limitation was the cultural context, because there was a limited exploration of behavior and cultural factors influencing the KAP. Recommendations to improve the study would be enhancing the program, integrating practical lifestyle interventions, expanding public engagement strategies to foster sustainable behavior change. And future research directions would include having those longitudinal studies to track changes over time, including a more diverse demographic representation to increase the generalizability of the results, and exploring cultural and socioeconomic barriers to behavior changes. Concluding insights are this. The key takeaway is that knowledge alone is not sufficient to drive behavior changes, and the significance is that there's now a foundational analysis for refining Posbindu and similar community health programs in lower middle income countries. For my project, planning began by looking into local health fairs. As I researched this and communicated with health fairs, it was just a dead end. There were not enough people willing to participate with my intervention. and risk it. I didn't want to risk not having the hours that I needed. So instead of directing my project to local health fairs, I contacted some local pastors that I knew, and they were very receptive to me and wanted me to implement my intervention in their churches and their communities. So, my project goal, again, is to spread awareness and education about hypertension, risk factors, prevention, and management to the CSRA. Objectives were to educate the community about definition of hypertension, community statistics, risk factors, hypertension prevention, and lifestyle choices. Other objectives I had were to screen at least 40 people and provide education to 80 individuals. I evaluated my completion of these objectives by completing a tally of each person who would stop by my station to speak with me, and I kept a tally of who completed blood pressure screenings. This is my implementation. This is just the schedule of hours I completed and where I completed them, what days of the week. As you can see, mostly them on Sundays and Tuesdays because that is where and when pastors allowed me to be there. On Sundays, I would complete my screenings at a local Aiken church campus, and then on Tuesdays, I would go to a college campus outside of the location where our Baptist campus ministry college group was hosted. Here are just some photos of what I did. As you can see, there's my trifold. I would just set up my station on a table. I made a little meme based off of just what I had seen on TikTok, and I thought that might get more engagement on a college campus. So, and it did. People stopped by and they said it was funny and they liked my meme, and then I would educate them about hypertension. These are the visuals I put on my display board, including the counties of which I was performing my screenings in. See, there's Georgia, that's Richmond County, and then this is South Carolina, and it's highlighting Aiken County. These are screenshots of the information that I put on my display board. What is hypertension? Why is it the silent killer? Risk factors, prevention, and hypertension within our community. This is my evaluation. For evaluation, I kept a tally of the conversations I had with every individual and each screening I completed. This just shows a table of screenings completed and educational conversations that I had per week. As you can see, the total I had completed 84 screenings and 123 conversations. That more than met my objectives from before. My original goal was to spread awareness and education about hypertension, risk factors, prevention, and management. Based off of my measurements and experience, I would say that I have achieved this goal. I have spread awareness and education regarding risk factors, prevention, management, and prevalence of hypertension to the CSRA. And these are my references. Thank you so much for watching. Have a great day.